Thank you. You all very much for showing up today. My name is Ichiro Nakajima, professor at Nihon University. I'm in charge of section. Can I hear? Can you hear? My section is behavioral science. Okay. The purpose of today's presentation is to share information on oral dysfunction problems in patients with oral cancer after the oral surgery. I hope you find the background of their problems useful from the point of view of clinical neuroscience. Thank you. Okay, anyway, I'll do why? I wanted to share. Sure. Chairperson, can you hear me? Okay. Okay, thank you. Everybody can watch video?
Cortical potential associated with jaw biting movement in the patients with oral cancer after the surgery. Today's presentation is shown on the slide. I would like to talk about the background and purpose of the research, the outline of the research, and future issues. As keywords, there are 5. Oral cancer, mandibulectomy, movement-related cortical potential, jaw movement, feed-forward system. This slide shows the oral cancer prevalence in the world. Oral cancer does not have a high incidence compared to those of other body parts. However, it is relatively high in Asian region, and many deaths have been reported. In Japan, 7,000 people also die from oral cancer every year. This slide shows a clinical case. The case is amyloblastoma. An X-ray is shown on the left and a histopathological image is shown on the right. This amyloblastoma often develops in the mandible. Both benign and malignant symptoms of extensive bone destruction are seen. In such cases, it is necessary to remove the affected bone. The oral tumor or cancer extensively destroys the jawbone. The surgical procedure is shown on the left, and the removed jawbone is shown on the right. As the cancer spreads extensively, the surgical field expands accordingly. Along with such excision, the affected bone is removed with the teeth, masticatory muscles, and peripheral nerve tissue. The slide shows an X-ray of a case in which the mandible was reconstructed with bone graft and metal materials after the oral surgery. In general, after partial excision of the jawbone, the morphological recovery is performed by transplanting the patient's own bone and repairing artificial objects such as metal. In addition, dentures are attached to restore aesthetics and morphology for the patients. Most patients are required to undergo the rehabilitation named eating function therapy in order to restore oral functions such as chewing and swallowing. In this way, this rehabilitation is necessarily carried out for a long period of time. This slide shows the changes in masticatory efficiency in 6 patients after mandibular reconstructive surgery. This index evaluates the performance of crush an artificial sample in the oral cavity by chewing within the specified time. As compared with before surgery, the masticatory efficiency was not sufficiently improved even 12 months after the surgery in the patient group. This indicates that it is difficult for the patients to obtain the recovery after the surgery in oral motor functions, suggesting a decrease in QOL in the diet. This slide shows an image of dysfunction of mastication in the patients after the surgery. Mastication is known to involve complex movements and sensations. Mandibular position sensation is transmitted from the muscle spindles to the central nervous system during jaw movement. Masticatory muscle activity is also subtly regulated by food texture information from the mechanical receptors of the periodontal ligament of the tooth. Before the surgery, the patient maintains these neural function systems. However, after the surgery, these sensory receptors were also excised with affected bone in the patients to remove cancer for saving their irreplaceable life. This delay of masticatory function recovery might be due to impaired oral sensory system in the patient after surgery. From these findings, we thought that it was necessary to establish an effective index of rehabilitation in jaw motor functions for the patients, based on clinical neuroscience. In this research, therefore, we examined whether movement-related cortical potential was an effective index of patients' brain function, focusing on their main symptom of difficulty in voluntary jaw movement. Movement-related brain potential, it is usually abbreviated as MRCP, is a negative potential recorded from the brain about 1 second before the start of voluntary movement. This figure is a schematic diagram of MRCP with button pressing as a voluntary motor task. This potential is obtained by averaging of electroencephalogram before the onset of the muscle discharge, preceding the voluntary movement. In this study, as shown on this slide, we first compared the characteristics of MRCP waveform components in jaw movement with hand movement in healthy subjects. The slide shows the waveform components of the MRCP. This potential can be classified into 2 main components, BP and NS. BP and NS are known to reflect the activity of the supplementary motor area and the activity of the motor area, respectively. In this experiment, we measured the peak amplitude and duration of MRCP in jaw and hand movements, respectively. The trigger point arrow indicates onset of the muscle activities preceding the voluntary movement. The slide shows the motor tasks and recording conditions in this experiment. The subjects were instructed to do jaw biting movement on unilateral side or wrist dorsiflexion movement. A shows the grand averaged MRCPs for wrist extension task over all 8 subjects. B shows the grand averaged MRCPs for jaw-biting task over all 8 subjects. Both waveforms were obtained from vertex, CZ. The BP component and NS component can be confirmed in each waveform. Onset indicates onset of muscle activities. Panel C and D indicate mean peak amplitudes values of the MRCPs for wrist extension and for jaw-biting tasks, respectively. The MRCP amplitude was significantly higher in the jaw-biting task than in the wrist dorsiflexion movement task. The MRCP recorded at CZ tended to be a large amplitude in both tasks, and was clear to distinguish 2 main components. Next step, we investigated changes in MRCP waveform components before and after surgery in patients with oral cancer. Seven oral cancer patients in whom the large area of the mandibular bone was excised during tumor resection were enrolled in this study. The patients ranged in age from 17 to 70 at the time of surgery. Additionally, they had upper and lower molars on the non-operative side, unaffected side. Their operation procedures were either segmental mandibulectomy or hemimandibulectomy. Regarding MRCP waveforms associated with the preoperative jaw biting, negative potential appeared bilaterally 1.5s before muscle discharge initiation. The precipitous negative potential appeared 500 milliseconds before muscle discharge initiation in all patients. Preoperative negative potential waveforms consisted of BP and NS components. However, BP and NS appearance became unclear in 4 of all 7 patients after the surgery. In only one case, BP and NS components were observed at both pre- and postoperative periods. Figure shows a typical case with reduced waveform components. In this case, the BP component was confirmed 1.5 seconds before the onset of masseter muscle discharge, as in healthy adults. Before the surgery, however, after surgery, the amplitudes of MRCPs were decreased so much that the BP component could not be confirmed. The NS component was barely confirmed in the waveforms. In addition, the BP and NS components could be observed in the MRCP waveforms when this patient was requested to perform wrist movement during the postoperative period. The MRCPs were compared between the peak amplitudes before and after surgery in the oral cancer patient group. The amplitudes of the MRCP decreased significantly in the patients after than before the surgery. Thus, it was clear that the cerebral potentials associated with jaw movement were affected in the patient after surgery. It is already known that the cerebellum is involved in the development of MRCP. In experiments with monkeys, it has been reported that MRCP disappears when the cerebellum is resected. It has also been confirmed that MRCP disappears in patients with cerebral infarction. Naito and his group revealed that inputs from muscle spindles and tendons are transmitted to the cortex, such as the supplementary motor area in PET studies in humans. Inputs from muscle spindles and tendons are involved in the feed-forward systems such as posture and position. Based on these, it can be considered that the decrease or disappearance of MRCP after surgery in patients with oral cancer is due to the decrease in sensory inputs from the sensory receptors. In this study, therefore, our data may suggest that marked postoperative reduction in MRCP amplitude in the oral cancer patients was attributable to decreased activities of the dysfunction of the feed-forward system of jaw movements. In patients with oral cancers, sensory receptors such as muscle spindles and periodontal ligament are removed as the tumor in the jawbone is removed. Therefore, the necessary sensory input to the brain is impaired for the manifestation of voluntary jaw movement. As a result, it has been shown that voluntary movement preparation dysfunction may occur. MRCP research has excellent temporal resolution, but has drawbacks in spatial resolution, such as the inability to observe activated sites in the brain. There is a limit to inferring postoperative changes in brain activity in patients with oral cancers based on changes in brain potential alone. The left side of slide shows a comparison between the topographic mapping data of MRCPs and the activation sites of brain activity recoded by fMRI in the jaw biting movement in healthy subjects. As further step, we plan to examine in detail the brain activity before and after surgery in patients with oral cancers by using both MRCP and fMRI together. By developing our research, we would like to establish an index of brain function that contributes to the development of masticatory and swallowing rehabilitation for patients. We concluded movement-related cortical potential was one of the effective indexes of patients' brain function to reveal their symptom of difficulty in voluntary jaw movement. We hope that our research will contribute to the postoperative rehabilitation of patients with oral cancers.